Hello guys, welcome to Pajon Imaging Hub. In today, radiographers and other health professionals education series, we look at how to make diagnosis of lung collapse, which is also known as atelectasis, in chest X-ray. Please don't forget to like, share, and subscribe to this channel so that you'll be notified when new video is released. Thank you. Welcome back. Now, what is lung collapse, which is also known as atelectasis? Atelectasis, most cases, is used to signify small area of lung collapse, but it can be used synonymously with lung collapse. It means the same thing. It does not mean just small area of lung collapse. So, lung collapse or atelectasis is the failure of all or part of the lung to expand due to loss of air in the alveoli. Now, there are mechanisms how these things occur. There are about 6 mechanisms that lung collapse could occur. The first one is obstructive or resorptive atelectasis or mechanism. The second one is passive atelectasis. We have compressive atelectasis, we have adhesive atelectasis, we have cicatrization atelectasis. And the last but not the least is the gravity dependent atelectasis. These are the mechanisms through which lung collapse could occur. In other words, lung collapse could occur through any or combination of these mechanisms. So let's look at what is obstructive atelectasis, or how it comes to cause atelectasis. Well, obstructive atelectasis, this occurs when airflow to a region of lung is interrupted as a result of airway obstruction. So when this occurs, the air distal to this obstruction is then reabsorbed, and this causes collapse of the affected area or lobe. The passive mechanism, this is the loss of volume as the lung retracts in the presence of pneumothorax. This is associated with patients that have pneumothorax. Compressive atelectasis. This results from compression of the lung by an adjacent space-occupying process such as a bronchogenic cyst, Buller, neoplasms, pleural effusion, or large osteophyte. When there is something compressing the lung, that can lead to collapse of the part of the lung. Adhesive atelectasis. This is atelectasis caused at least in part by deficiency of surfactant. We know surfactant is what keeps the lung open, the alveoli open. So if the alveoli lacks surfactant, it will collapse. So surfactant reduces the surface tension of the alveoli as their surface area of volume decreases, thereby effectively protecting against collapse. That is the work of surfactant. Causes of adhesive atelectasis in adults include radiation pneumonitis, smoking. Smoking inhalation can cause either active smokers or passive smokers. They can have high risk of having adhesive atelectasis. Then acute respiratory distress syndrome and pulmonary pneumoembolisms are causes of this adhesive atelectasis. Then the other mechanism of atelectasis is this cicatrization atelectasis. This is loss of volume due to pulmonary fibrosis. When there's fibrosis in the lungs, there's tendencies of some of the alveoli being destroyed, and there is high tendency of loss of volume. The last but not the least is gravity-dependent atelectasis or mechanism. This occurs due to patients not fully expanding their lungs while lying for long periods. This could be due to the weight of the lungs and the effect of gravity, because the patient is staying for on a particular posture for long. So the weight of the lung on that part, the most dependent one, with the help of pull of gravity, there is tendency of collapse of that place, especially the posterior portion of the lungs when the patient is lying spine. The tendency of collapse of those those posterior portion of the lungs that is closest to the ground. So these are the mechanisms through which atelectasis can occur. Then we'll look at type of atelectasis based on anatomical extent, the extent of the part of the lung that they cover. We have lung atelectasis, where one part of the lung is collapsed. Could be right lung atelectasis or left lung atelectasis. We have lobar atelectasis. We have upper right lobe, middle lobe, lower right lobe, upper left lobe, and lower left lobe. This could occur. We have segmental atelectasis and subsegmental atelectasis. These are small type of atelectasis when a little or small area of the lung are involved. Then we look at type of lobar collapses or lobar atelectasis. I've mentioned them: the right upper lobe collapse, middle lobe collapse, right lower lobe collapse, left lower upper lobe collapse, and left lower lobe collapse. We don't have left middle lobe, but we have the lingula, which is part of the upper lobe. And we're going to see where the lingula is more affected and where it is not more affected. There are features to show that distinction in collapse. Radiographic signs of atelectasis or collapse. There are two major signs we look out for: the direct signs and indirect signs. The direct signs are displacement of the interlobar fissures. We look for where is lobar fissure supposed to be. We'll now see whether they are displaced and to what side. Then we'll look at crowding of bronchi and vessels within the area of atelectasis. Where there is crowding of vessels or bronchi, then we'll have to suspect there is probably collapse of the lung, because these bronchi and the vessels are trying to accommodate themselves in the small area that they have been collapsed into. Indirect signs include pulmonary opacification, which is the one we commonly see. But we have to be careful to be able to differentiate pulmonary opacification that is caused by consolidation, which does not involve collapse, and the one that actually involves collapse. It is very important. The other feature, indirect signs, is diaphragmatic displacement. Mediastinal structure shift, like the trachea, heart, hilum displacement. To what side were they displaced? That too signifies the kind of collapse we have. We'll have overinflation of remainder of the ipsilateral lungs. When there is a particular area that is highly inflated and still devoid of pneumothorax, then we should suspect there is an area of the lung that may have collapsed. Then shifting granulation or any other previously documented lesion. The collapse always is associated with shift of structures towards the area of collapse. If there is a lesion that is already known and the location is known, then if we see a move or shift of this granuloma or lesion, then we should suspect collapse in the area it was or it is shifted to. Then crowding of the ribs because of the little area. If the lung collapse, then the thorax area is reduced. Is expected to be reduced. So the ribs have high tendency of crowding together. These are indirect signs of atelectasis or collapse. The lobar collapse one by one. We'll start with the right upper lobe collapse. Let's look at the features before we look at the radiograph. Features of upper lobe collapse. That these are features you may see in upper lobe collapse. There is increased density in the upper medial aspect of the right hemithorax, where the upper lobe is located. Then there is elevation or superior bowing of the horizontal fissure. The horizontal fissure will tend to shift up. Then elevation of the right hilum, it will tend to be pulled up. Then loss of the normal right medial mediastinal contour. That is the part of the heart that is in contact with the upper lobe. The area, the border will not be distinct. Then hyperinflation of the right middle and lower lobe. We'll call it compensatory effort, so that they can meet up with the requirement of oxygen need that is expected from the right lung. So let's look at this image I place here. And so we see this area that is upper lobe collapse. We see that this part of the heart is not distinct, and we see the superior bowing of the horizontal fissure. So these are features of upper lobe collapse. And if we look closely in this area that is collapsed, we don't see any sign of air bronchogram. So it is not mnemonic changes. It is not consolidation. So it's a collapse. You see, they appear uniform. There is no area of any black lines seen. So these are features that distinguish consolidation from a collapse. We'll look at this one, right middle lobe collapse. Let's look at the features that we can see in any right middle lobe collapse. The first one is you can see right mid to lower zone air space opacification, where this is a region where the middle lobe is located. The normal horizontal fissure appear not visible because they are distorted. For you to see any border, it has to be at right angle to the beam. But now when there is a middle lobe collapse, the horizontal fissure is no more in a right angle with the beam, so you cannot see it. Then the obscuration of the right heart borders, you don't see the right heart border clearly. Increase opacity to the right heart borders, because the collapse there, that area of the right heart that is in contact with the middle lobe, that is the right heart border, and it will not be distinct. There will be a high opacity as increased density in that area. There are other signs you may see middle lobe collapse. Let's look at the image we have here. So you see the right heart border is not clear. You see this opacification here. That signifies middle lobe collapse. You cannot appreciate any form of horizontal fissure here. Then the next image is right lower lobe collapse. We'll look at the features first. What are the things we see in the right lower lobe? The features of right lower lobe collapse. You see a triangular opacity extending from the hilum to the diaphragm. The apex points towards the right hilum. We'll see that in a moment. Obscured medial lobe, medial right diaphragm. The diaphragm will not be clear, but that is the medial aspect. An inferior displacement of the right hilum, because it will be pulled towards the lower lobe. And distinct right heart border in contact with normal middle lobe. If the middle lobe is not involved, the right heart border will be distinct. You'll be able to make out the right heart border, because the right heart border is majorly in contact with the middle lobe. Then inferior displacement of the horizontal fissure. So because the collapse is downward, so it will tend to put the hilum and the middle lobe fissure down to itself. There are other signs you may see in a right lower lobe collapse. Let's look at the image. We have two images here to take note of. We'll see we'll see the triangle I talked about. This is too big here, this small one. See the triangle. You see the apex is pointing to the hilum. So you see these areas are opacified. And this medial aspect of the diaphragm, you can't see it clearly, is opacified. It's not distinct anymore. That is a sign of right lower lobe collapse. Look at this other image. You see there is a double heart border. There is opacity here. This is the right heart border. There is opacity there, and that opacity even extended to here also. So this is the right lower lobe and the left lower lobe collapse. We're going to see left lower lobe in a moment. They always have that triangular appearance. Lower lobes collapse. And the next image is a left upper lobe collapse. Let's look at the features you can see in left upper lobe collapse, because before we look at these images I have here, features of left upper lobe collapse. One is appearance of hazy or veiling opacity extending out from the left hilum and fading out inferiorly. The left heart borders may be obscured, especially where the lingula is involved. It covers the right heart border, the left heart border. It will not be distinct. Then the arterial aspect of the aortic arch are also often obscured in left upper lobe collapse. There can be other features you will see. And you see these image, the down one, you see this right part of the heart, the hilum also is obscured heavily. You see how they are emanating from the hilum. Now here, the lower border of the heart appear to be free. That means the lingula is not highly involved. So look at this one, this upper one. We see that the whole of the left heart border are obscured, but the diaphragm is clear. So this one involved is upper lobe collapse, but involve greater aspect of the lingula. That is why this left heart border is obscured. Let's look at this one, the left lower lobe collapse. Let's look at the features before we look at the image. Features of left lower lobe collapse. There is triangular opacity in the posterior medial aspect of the left lung. I've mentioned that before, that lower lobe collapse always show that triangular opacity, with the apex pointing towards the hilum. Then left lower zone opacification, usually medially, with the apex pointing. That is what I just said. Then edge of the collapsed lung may create double cardiac contour. We're going to see that in a moment, and I've shown that previously also. Then inferior displacement of the left hilum may be seen also. So let's look at this image here. We'll see a double heart border. See this first one and the second one. Then we'll see the triangular opacity. Triangular opacity with the apex here pointing towards the hilum. That is a feature of left lower lobe collapse. The next image is a lung collapse. But we have to be careful when we see lung collapse, right or left lung collapse. We should be able to differentiate it with pneumonectomy, which involves removal of this part of the lung. In a lung collapse, you can see the mediastinal structure being shifted to the side of the collapse. You can see the bronchus shifted to this side. You can't even appreciate any sign of heart border in this right side. All of them are being shifted to the collapse region, the side. Then of course we see the opacification. And if you look inside, we cannot appreciate any air bronchogram. They appear uniformly opacified, except for this bronchus we are seeing here. And we'll come down to these pneumonectomy. The feature that help us differentiate pneumonectomy from lung collapse is we have to look closely to see the abrupt ending of the bronchus. You can see how this one ended here. If you look closely, we see the surgical clip. That can equally help us to distinguish between pneumonectomy and lung collapse. You see the surgical clip. So it's white, it has a higher density. In terms of the opacification, we can't be able to differentiate between lung collapse and pneumonectomy. It is difficult. Of course, we see that the mediastinal structures, it pulls down towards the area of the lung that was removed. You can't appreciate any right heart border. They have been pulled out this area. So these are tiny things we need to know to be able to make the right diagnosis. Please like, share and subscribe to this channel so that you will be receiving a notification of new videos, and try to follow this teaching closely. We are gradually covering details of image interpretation, and the end, when you put these details together, that is what will form the image interpretation lectures.